So thank you everybody for joining us tonight. It's an absolute pleasure to be here with the opportunity to show off what we've been doing. If we go on to the next slide. As a midwifery ambassador, I remember going to my midwifery ambassador training with Jackie, and Jackie had three very top priorities when she was new in post, and one of them was the pelvic health service. Another was to raise the profile of our profession and also the leadership in our profession. Pelvic health is very close to my heart, and little did I know then that I would be the LMNS midwife who submitted a bid to be an early implementer in January 2021, and we were successful at that. We're one of 14 in the country, and it's been a really exciting place to be. Raising the profile of women's health and perinatal pelvic health is really important. So that's the quote from our Chief Midwifery Officer there. So there's three national drivers that are really important in this project. And the first is to prevent and mitigate pelvic floor dysfunction resulting from pregnancy and childbirth. And that includes things like routine antenatal education, adherence to the pelvic floor muscle training, baseline self-assessment at booking, and additional targeted antenatal and postnatal care for those that are more at high risk. For example, those who've had an assisted delivery or third or fourth degree tears, those with a raised BMI, those that don't speak English or maybe have a lower level of capacity for reading and things like that. And also to adopt practices that mitigate risks such as the OAC bundle of care, as well as the quality wound care support. The second one is improving the rate of identification of pelvic floor issues, and that includes the provision of quality information for not just women and families, but also staff, and including the wider primary care team. And an assessment tool to help clinicians and women and birthing people to identify risks and issues as well. And the third one is ensure timely access to NICE recommended treatment, which also includes establishing the service as a single point of access and a one-stop clinic service, reducing the referral to treatment times, and increasing a local establishment of specialists, physiotherapists and midwives, and providing the leadership for local planning in services.
Thanks, Zoe. So just before I go on to talk a bit more about the problem and the background to why we were so keen to be part of the early implementers of the Perinatal Pelvic Health Programme, our Perinatal Pelvic Health Services come about as a huge collaboration between a lot of people. So I'd just like to say thank you to everybody who's been involved, from NHS England down to all of our lovely colleagues who've been referring women and birthing people into the service, identifying people early, getting them treated. That really is key to all of this. So if we have a little look now, dig into the background of why is it so important? Why is it important to have these perinatal pelvic health services, and what's the impact? So as most of you will be aware, women's health issues tend to be marginalised. There doesn't seem to be as much research into women's health issues as there are to other aspects of health and social care. So that's particularly the case when we're talking about childbirth, injuries sustained during childbirth, perineal trauma, postnatally and during pregnancy. Perineal wounds currently, prior to perinatal pelvic health services, there has been very little specialist provision for follow-up care for women who sustain perineal trauma or pelvic health problems during pregnancy and the childbirth continuum. Infections, it was often the case that women with perineal wound breakdown or infections would have to see their GP and would often be prescribed antibiotics. And there wasn't any real specialist provision, as I say, for following up and monitoring wound healing, because obviously GPs are extremely busy at the moment. As you'll be aware, wounds that have broken down heal by secondary intention. So where there's been an infection, the wounds take longer to heal. and that's a longer, more painful process, and often leads to the formation of granulation or overgranulation tissue. And we'll talk a bit more about some of the treatments we're able to offer through the service for that later. Not only the physical aspect of perineal wounds, but also the lifelong social and psychological implications for birthing people are starting to come out more now, and there's more awareness around that. Historically, women have been reticent to seek help for obvious reasons. They find it an embarrassing thing to do. It's exhausting, having to access multiple resources, multiple healthcare providers, and it's such an intimate problem that, you know, exposing those parts of your body to multiple different people is obviously very challenging, and that's traumatizing. And feelings of abandonment and isolation are commonly reported by women who sustain pelvic health and perineal injuries during birth. From a pelvic health point of view, prolapse is very, very common, affecting about 1 in 3 women who've had children. And lots of you will be aware that serious pelvic girdle pain is very prevalent in with pregnancy and with birthing people. So about 7% of women postpartum, and many, many more antenatally as well. Birthing people report being irreparably damaged by pelvic organ prolapse. So it's really, really important that services are there to support women and birthing people experiencing that. And of course, it's not just an impact on the service users. There's a huge impact for the NHS. Obstetric injuries are the 4th highest reason for claims in obstetrics, and the total value of costs and claims in that area are estimated to be around £48 million per year. 85% of those claims are related to misdiagnosis of perineal trauma. So it's really, really important that we've got those fundamental teaching processes and skills in place at an undergraduate and a post-qualification level as well. And there's the ongoing cost of surgical repairs in theatre and subsequent deliveries by caesarean section, potentially. In terms of the incidence and prevalence, it does appear that the rates of obstetric anal sphincter injuries are on the rise. But fortunately, the incidence of perineal tears decreases with subsequent births. We're hoping that with better education and a more intense focus on pelvic health issues, we're hoping to see those rates come down. And actually part of the NHS England national KPIs, one of the key performance indicators is to reduce the rates of obstetric anal sphincter injury. So we're hoping to be successful with that.
So in 2020, our Kerno Maternity Voices Partnership surveyed service users across Cornwall and the Isles of Scilly. And this is just a few of the highlights, really, that you can see from the percentages there that actually midwives who discuss ways to minimise or prevent perineal trauma was actually very few. And the blues are those that answered positively and said yes, and then the oranges are those that answered negatively and said no. We also know that service users didn't know where to access information on pelvic health. Symptomatic service users being referred to NHS physios were fewer than who needed them, and pelvic health negatively affecting their mental health. That was a high number, and those who had a negative impact on their sex life and intimacy and relationships. The other highlights is that there was little awareness of a chance of pelvic pain or fecal or flatus incontinence, which was a real eye-opener. Yet 85% of service users surveyed were aware of the likelihood of leaking, which it was very suggestive of it being a normal normalised, which obviously we needed to change the narrative over. And then the recommendations from the report were very much about increasing information and knowledge, training, supporting clear pathways for service users to access further support. So we were really able to utilise our Maternity Voices Partnership survey and the results with what we were going to be doing locally. So we really developed our service and our ambitions for our service around what our service users actually said. And actually we were very congratulated in our bid for doing that. So that would be one thing I would definitely recommend, is liaising with your Kerno Maternity Voices Partnership in order to, or your, not Kerno, but your Maternity Voices Partnership, in order to ascertain what your local population are needing.
So we thought we would tailor this to Cornwall and give you an overview of some of the statistics and make it relevant to this area so that you can see why it was necessary. This is an overview of the different types of perineal trauma that occurred in our trust during 2020 to 2021. And you can see broadly it fits in with the national data that the highest rates are of the first and second degree tears. Episiotomy we know occurs in about 1 in 7 births, but that does fluctuate between areas as well. And thankfully we had quite low statistics of 3rd and 4th degree tears, but again, that's always subject to change. And one of the really important aspects of the pelvic health service is that we're scrutinising the data a lot more closely now, and trying to find and extrapolate themes as to why and what might be causing these, to see if there's anything that we can do proactively to change that. I should point out that these statistics don't include anything around pelvic organ prolapse, pelvic floor dysfunction, and our physiotherapy referrals. This is purely around the obstetric statistics. So we thought we would show you a short video. It's 5 minutes, just a quick summary of what we're doing. This was shared with NHS England and it is available on the Futures platform, but we thought it gave just a good coverage and a good introduction to who we are and some of the other people that are involved in this fantastic project.
Hi, my name is Zoe Nelson. I'm LM&S lead midwife for Cornwall and the Isles of Scilly. I'm leading our Perinatal Pelvic Health Service and our Early Implementer project. I'd like to introduce you to our project team, who will take you through our history of our project and the vision for the future. And it's something that we're really excited and passionate to be able to bring to you today.
Hi, I'm Rachel Mullins. I'm the Specialist Pelvic Health Midwife for the Early Implementer Pelvic Health Project at Royal Cornwall Hospital.
Hey everyone, I'm Rachel Collett. I'm the Pelvic Floor Dysfunction Clinical Lead Physiotherapist.
So the idea for the Pelvic Health Clinic initially came up about 3 years ago when I was working as a community midwife after spending some time working as an acute midwife in the hospital. I felt that Cornwall would really benefit from having its own perineal pathway to follow up women who'd sustained perineal trauma during childbirth. So I submitted an Improve Well idea through the Improve Well app, which was a way for frontline staff to submit their ideas and for them to be actioned and implemented.
The idea was supported by Zoe, who was my matron at the time, and so I went on to present to our head of midwifery, our specialist consultant, the LM&S and Kerno Maternity Voices Partnership, and the project has grown from there.
I'm Nikki Burnett, Chair of Kerno MVP. The MVP worked alongside Cornwall LM&S to develop the Postnatal Care Action Plan in line with the guidance on postnatal care published by NHS England. To support this work, we developed and conducted an online survey and engagement to examine what the current offer looked like and how service users felt about the support which was offered to them. We asked women and birthing people about their experiences and asked them to share the impact their pelvic health and subsequent care had on their mental health, their physical health, and their sexual relationships. The findings from this engagement are what informed and influenced the design of our pelvic health service and subsequent application to be an early implementer site. It was important to us to ensure the voices of those that would use the service were present right from the start and that service was built around their needs.
Over the last 18 months, the pelvic floor physiotherapy service consisting of myself
and Kirsty Sturgeon have been working alongside Rachel Mullins and other services trying to plan a more robust service for all women with perineal trauma following delivery. Our driving force for this has been that we feel all women who sustain perineal trauma should have equal access to an MDT approach to manage their perineal trauma and pelvic floor muscle training.
From the outset, collaborative working, equitable care, and being able to offer meaningful evidence-based support and treatment to women and birthing people in Cornwall has been at the heart of this project. Cornwall and the Isles of Scilly are incredibly proud to have been chosen as an early implementer site. We've considered and reflected on potential challenges as Cornwall and the Isles of Scilly have a unique geography which can make delivering accessible healthcare difficult. Our one acute maternity unit covers the whole of the county, and our community midwives and physiotherapy teams are spread over a wide area. However, our vision and commitment to improve perineal and pelvic health locally and nationally is already having a positive impact. During the preparation for our new service, women and birthing people have come forward to express their hope and relief that such support will now be available. Our project team have the diverse range of knowledge and skills to achieve our goals. We're enjoying networking and sharing ideas with other early implementer schemes, and our team are part of national forums of specialists who share our passion for improving perineal and pelvic health. We are working with our clinical school to implement research in this area and are very excited about what the future holds.
Brilliant. So hopefully that just gave you a really brief overview of some of the things you've already mentioned, but and gives you a bit of background into to what was going on down here. We touched on it a little bit in the video, but in Cornwall, prior to the establishment of the new service, there was limited provision. So limited follow-up for those people sustaining first and second degree tears, episiotomies or perineal wound dehiscence. And as we're all aware, there's a national shortage of midwives as well. So the routine postnatal midwifery care is often limited to what the service can provide at the time. So we're not always able to provide that in-depth follow-up, particularly regarding perineal care and pelvic health issues as well. Those sustaining third and fourth degree tears will have a routine appointment with an obstetric consultant, which is a fantastic follow-up. However, again, due to the sheer volume of work, those appointments can be delayed and advice can sometimes differ between areas. And that's certainly something we've noticed nationally. As I say, there's a consultant-led perineal clinic for symptomatic third or fourth degree tears, which is run by our wonderful consultant. But again, time is limited and so is the funding for that. We do have a specialist pelvic floor dysfunction physiotherapy service, and we've worked very, very closely with the physios from that service to implement the perinatal pelvic health service as well, which we'll talk about a bit more in a moment. Our aims overall, though, were to have continuity of carer. That's one of the key aspects of this. And as you said at the beginning, Sue, we know the value of that. There's plenty of evidence underpinning how valuable that is. And good education. So as we said, pre-reg and post-reg, really, really important to have that ongoing and developing education, because as we want everything to remain evidence-based, and obviously things change as research is released. We wanted improved antenatal and postnatal resources. That was something that came out of our Maternity Voices Partnership survey. And we wanted a single point of access for all the referrals and self-referrals. That again was something that NHS England were very, very focused on, and something we felt was really, really important. Because again, we wanted to simplify the process as much as possible and make it as efficient as possible, so that we can see those people who need it most as quickly as possible. We want an inclusive and easily accessible service for Cornwall. And we're hoping to develop an online pelvic health hub that can be accessed by any women and birthing people in Cornwall and their families as well, because we don't have time to get into that today, but the families of women and birthing people experiencing the symptoms and the conditions that we've been talking about, they're often very, very severely affected as well. We're aiming to expand our provision to other types of perineal trauma and pelvic health issues. At the moment, we've had to implement a phased criteria for who can access the service. And Zoe will talk to you a bit more about that in a bit, but we've had to limit it, and we're hoping to be able to expand that as time goes on. We've talked already briefly about quality improvement, so I won't stay too long on this, but essentially this is the pathway that we took. Zoe drove it forward with a quality improvement pathway, and which started in 2019, and that our clinics actually opened in December 2021. As I say, our current referral criteria are quite limited, and this is just an overview of who can access the service at the moment. And again, we're hoping to expand that. We're able to see all of those with 3rd and 4th degree tears, episiotomies, all forms of FGM, fistula, and those that are readmitted to the hospital for any sort of perineal wound complication or suspected wound dehiscence or infection. The physiotherapists in particular are following up those who've had a manual removal of placenta, had a breech delivery or a multiple birth, women in birthing people who've been involved with shoulder dystocias, and instrumental deliveries and large babies, and also a prolonged second stage, because the impact, those risk factors are known to have a bigger impact on long-term and short-term pelvic health. And crucially, we're having self-referrals into the service. We're really encouraging that and trying to share that with the midwives and all of our allied health professional colleagues, so that they can spread the word and women and birthing people feel enabled and empowered to self-refer. Currently, we're seeing women and birthing people up to 12 months postnatally. Again, that's something that hopefully we'll be able to expand in time, but it was necessary to limit that, and that was the NHS England guidance. So at the moment, as I say, we're having this phased expansion of the referral criteria. The physiotherapists and I run 2 clinics per week at the hospital in Truro. There's always a physiotherapist and always a midwife present at each clinic. So if there are multiple issues, then we can liaise and people get seen in a timely manner. They don't have to come back for multiple appointments and such like. We, the clinicians, triage the referrals as they come through into that one-stop referral service. And we contact women and birthing people to provide the initial assessment and treatment and make an individualised care plan from then on. As I said, we have a team continuity of care approach. We found that invaluable, and the feedback so far is that obviously our service users feel that's a benefit as well. If necessary, we're fortunate that we can make onward referrals into our day assessment unit for acute cases, and we can also refer on into the bladder, bowel and birth reflections and services as required. So just to give you an overview, we do go into some of the challenges that we've had later on, and we touched on it earlier, but geography is certainly one of them. You can see that there's the one unit in Truro, and that's where we have the main PPHS clinic, and our main community physiotherapist is based there. But we've tried wherever possible to get coverage across the county. So we do have a community-based physiotherapist within the pelvic health service in Bodmin, and we have another physiotherapist further west down in Camborne and Redruth. But you can see that the geography is a potential challenge. In terms of the treatments we're able to offer, they're expanding all of the time, and we've had brilliant support from our obstetric consultants to really expand that provision with an evidence-based approach. So we provide individualised care planning for perineal trauma and pelvic health risk factors, and that includes starting discussions about future mode of delivery after having an obstetric anal sphincter injury. A lot of the feedback that we have from people that we've seen has been, it tends to go 2 ways. Some people say they wish they're glad they didn't know about the potential for obstetric anal sphincter injury prior to birth, and other people say they wish they did know. So again, like I say, it's individualising that care planning, and that touches on education and awareness as well. Wound care and monitoring, that's probably the main thing from the midwifery point of view. that we monitor the wound care, we monitor the wounds, and we provide treatments. We talk about perineal massage for scar tissue, and we try and do antenatal and postnatal education around that. There is the option for resuturing, and there have been some cases that have come through the Perinatal Pelvic Health Service that have gone on to have resuturing or surgical repairs. We talk about defecation dynamics, how to improve people's well-being postnatally. We can apply silver nitrate for granulation, over granulation, which again is having really, really good positive results. And we've had great feedback about that as well. And we do topical antimicrobial application as well. We've talked briefly about the clinical team, but we have two great consultants on board. Farah is our consultant urogynecologist and an obstetrician. John's our consultant obstetrician. And then there's me as the midwife, two senior physiotherapists and three fantastic community physiotherapists based across Cornwall, as we said, just to try and bridge the gap in geography across the county. We've got our single point of access set up now, and that's been great. We have found that that's been a really simple and effective way of monitoring all of the referrals that come in. And as I say, we triage those referrals, and we collaborate with other services within the trust. So it's been a steep rise in demand for the service since we started in December. You can see, I think, on our first clinic that we started on 3 appointments, and that rapidly rose to 158 by March of this year. Across all of the physiotherapy and midwifery appointments, we've seen more than 550 people, and had more than 550 appointments, certainly, since December 2021. And as I said earlier, we've had two referrals for surgical treatment, quite significant surgical treatment.
So it's really important to understand some of the challenges which anybody listening that is submitting to be a fast follower or thinking about the service that they might have in the future. It's really important that we talk to you about our challenges, because I think you probably could gain quite a lot from that. Geography we've already talked about. Obviously we span a large area, and accessibility was something really important to us, but we've only been able to have the 3 different clinics in the 3 areas that we've already pointed out. I think it's really important to think about our staffing and the funding that we were given by NHS England doesn't actually support our staffing wages at the minute. So we are having some challenges around it being a cost pressure. Each of our community physios do one clinic a week for the pelvic health service, because they're 0.2 each, and so therefore there's limited capacity. The specialist midwife, Rachel's a 0.6, which is not even enough full time, so there is some real capacity issues around that. And then we've got the 0.8, both Band 7 physios are 0.4 each. So there is some real tricky demands over capacity, and that will be negative, have a negative impact on our delays to follow up. We're already seeing that our clinics are really booking up very fast. And one of the national KPIs is about referral to treatment time. So it will be something that we'll be monitoring. There is no capacity for any project management. As the LMNS lead midwife, I've been project managing it so far. However, this in the current challenging times is likely to change, because my role will be required to do other things, as I'm sure you're all aware. The IT systems are really tricky as well, because we're not an ICS. So we've got our Cornwall Foundation Trust and then our acute trust, and there is different IT systems. So there's no single place for documentation, and that's a challenge and something we'll have to overcome. We have got dedicated clinic space at the minute, but things always change. So it's to ensure that we keep that resource. It was quite tricky to get that resource in the first place. And as we increase if we're able to increase our clinics, if we get further funding, then we'll obviously have issues with our clinic space. Accessing our wider primary healthcare and our community for education and training and raising public awareness is going to be challenging, especially with the footprint that we've been given for our staffing as to who we can do that with. So we're liaising very closely with our public health colleagues who are very keen to support. So it's good links with our council has been really invaluable. Our inclusion criteria, we would love to increase our inclusion criteria so it's accessible for everybody. Again, if we can't increase our staffing, that's not going to be necessarily possible. Something that was a huge learning curve for us was how our services are commissioned. So Rachel's already talked about the pelvic floor dysfunction service, the PFD service, and that's a commissioned service for already. So for us to change that and bring it into our pelvic health service to be a holistic service, we'll have to do some work with the commissioners. And that's going to be quite politically tricky, I would imagine. So that's been a huge learning curve for us, because we thought we would bring everybody into our pelvic health service and we'd have a holistic service, and we would be starting off with those that are most at high risk. And that's not been the case. We've had to keep those that are high risk in the PFD service and the MSK service. And we take the criteria of the women that weren't being seen at all, that didn't have a pathway. So that's been a big learning curve for all of us, and something that wasn't highlighted to us when we were liaising with the relevant stakeholders in the first place. And then also the national KPIs and our data collection is going to be a challenge because of what the national team are asking of us. We're needing to survey every single service user postnatally, and they already have the friends and family, etc., etc. So it's how to bring that together so it's not going to be an inconvenience to our service users. And then also they're asking for a survey through the pelvic health service, or anybody who accesses the pelvic health service has a survey as well. So which would be probably a bit easier than the wider population. So there are some challenges, and we're learning as we go along, but we've got a really good team and support from the national team who are listening to us, and hopefully will support those fast followers and everybody else to come on board at easier times as well.
So going forward, this is our aims. These are some of our aims for the future. We've touched on some of them already, but we're aiming to contact and train GPs and allied health professionals in Cornwall about how to refer into the Perinatal Pelvic Health Service, and of course about the referral criteria. We're hoping obviously for an expanded service provision and continued collaboration with other pelvic health specialists at a national level. And I think the one really, really positive thing that has come out of the NHS England promotion of perinatal pelvic health services is that there's so much more taking place on social media. In the media generally, there are conversations. So I've noticed, for instance, in The Guardian, and on social media, lots of other platforms where previously those articles and those topics weren't discussed, they're now being discussed nationally and internationally, which is brilliant. And there are groups forming now of collaborations between perineal midwives and physiotherapists, which is brilliant. We'll carry on collaborating with our fantastic Maternity Voices partnership and get as much service user involvement as possible. We're very conscious that the service it started being driven by service users, and it needs to continue to be what service users want, not what we perceive is needed. An improved digital interface, including online referrals, would be fantastic. That would simplify things for us immensely. And we've said already, improved training and practical support for all healthcare providers. So we've liaised with health visitors and others that are seeing women and birthing people postnatally and providing support so that they know about us and how to access the service. We're really keen to take part in and contribute to research. That's something that interests me immensely. And we're looking at ways to do that as a team. and to influence the national pelvic health agenda and advocate for Cornwall as a centre of excellence. And that's us.
So yeah, I'm happy to share anything that we can with people who want anything. Our emails will be on the presentation and our Twitter handles there. You can see. Happy for anybody to contact us.